Welcome back to the podcast. In this episode, we're going to be speaking about the first decade of national coverage of the EMRS, so the Emergency Medical Retrieval Service in Scotland, with Ryan McHenry. So, we're going to explore in the episode the evolution and achievements of Scotland's Emergency Medical Retrieval Service as a critical lifeline for unwell patients in rural and remote areas. So the EMRS was established in 2004, but it's also transformed the way emergency care has been delivered in Scotland. So it's expanded its reach nationally from 2010 and opened a second base in Aberdeen in 2019. So the service operates within Scotland's Specialist Transport and Retrieval, or ScotSTAR division of the Scottish Ambulance Service, providing vital pre-hospital critical care and retrieval services. So what we're going to do today in our discussion with Ryan was really talk around the comprehensive study which Ryan published. It's a retrospective cohort study covering the first decade of the EMRS's national service. So we're going to discuss the key findings, including significant number of taskings, the crucial role of geospatial modelling in reducing transfer times, but also the service's targeted support for socio-economically deprived areas. We're going to delve also into critical factors associated with clinical deterioration and indeed pre-hospital mortality, and learn how the EMRS addresses these challenges. And we're also going to explore the future directions for the service and indeed the ongoing efforts to provide emergency medical care and address inequalities within Scotland. So welcome, Ryan, to the podcast.
Thanks very much for having me on. Yeah, it's great to be able to talk about some of this work from the north.
Ryan, I just wanted, as we start, could you maybe just unpack a little bit of your background for listeners?
Yeah, so my name is Ryan McHenry. I'm an emergency medicine registrar in the west of Scotland and also a clinical research fellow sitting within EMRS and ScotSTAR, doing clinical work with the service, but also with a research component, particularly looking at the effect of social deprivation and geographic isolation in pre-hospital care.
No, that's fantastic, and I think we'll dig into both of those actually in the interview. But maybe if we could just start with how EMRS has evolved since its establishment in 2004, and indeed what was some of the key milestones in its development.
Yeah, so to begin with, I think I should probably acknowledge that I've only been with this service for 3 years. So there are definitely people out there who can probably chart that development and the evolution of the service more accurately. But broadly, the service was established in 2004, and from its inception has been there to mitigate geographic inequalities in care in Scotland. And there was a recognition at that time that if you're critically unwell in remote and rural Scotland, you're likely to benefit from early critical care interventions, both before you transfer, but also during transfer, to try to make that transfer to the larger centres safer. And alongside that, there's been a real ethos to try to support rural clinicians who do a really phenomenally difficult job, often in very isolated circumstances, often on call for weeks at a time, and to try to give them some support whenever they're looking after critically unwell patients. And I think the story through all of this is the ever-present reality of Scottish geography. So has a population of 5.4 million people. It's got 77,000 square kilometres and 93 inhabited islands. And amongst all that, it's got a population density that's 6 times lower than England. So whenever you have a country that has that, and whenever that's the geographic context that you're looking in, you really need a service that tries to respond to those geographic inequalities that exist. Since 2004, there was a gradually expanding coverage from initially in a small area of the West Coast to cover the entirety of the West Coast and the Western Isles. And then national coverage came in 2010. Over that time, the service shifted with a role of primarily providing critical care retrieval to also providing pre-hospital critical care, with a recognition that that was something that was being delivered more and more by other services. And with the development of the Scottish Trauma Network in about 2016, 2017, that led to the creation of the second base in Aberdeen in 2019.
No, that's fantastic. And I think, one of the characteristics of the service, and indeed of the Scottish Ambulance Service, is really this increasing demand profile over time, and actually matching supply with demand. So matching coverage of air assets and indeed land assets with the demand profile. Could you maybe speak to the the expansion of the EMRS and indeed the second base in Aberdeen in 2019? Was it a purely a coverage component from your perspective, or was it just a to match the demand profile across the geographical area?
Yeah, so I suppose both of those things are a really key component to it. So first of all, I suppose there's a capacity element to it where if you only have a single base working in one part of the country, you simply cannot cover the rest of the country in reasonable time frames. So it makes sense to base another team at the other side of the country in Aberdeen. And I suppose from an operational perspective as well, that even just the way that Scotland looks, so the configuration of the geography is that actually whenever you try to encompass places like Shetland all the way down to the Scottish borders, actually that is not just a very large country, but it's also a very long country. So having a team that is based further north really allows you to be able to deliver better coverage to those northern islands in the kind of time frames that really we're looking for whenever we're delivering modern medical care.
Yeah, no, indeed, absolutely, and like you said, it's not only about coverage, but it's about response times as well. So making sure that, especially with emergency care, stroke, cardiac, Kennedy, trauma, it really is reliant on appropriate response times. Could you maybe speak to the operational data from your perspective? What are some of the key statistics between 2011 and 2020? Around taskings and indeed types of missions which prompted an expansion and growth.
Yeah. So these services, they're quite complex services, and I think you can probably broadly define the role of EMRS into three different strands. So that is critical care retrieval, which is mostly from remote and rural healthcare sites where people have already been looked after by a clinician, but they need moved to a larger centre safely. Second is pre-hospital critical care, and that plank of supporting rural clinicians leads to the third aspect, which is the provision of clinical advice to remote and rural clinicians who often have not spent a great deal of time looking after. Sorry, I'm going to try that one again. Can you just?
Yeah, no, that's absolutely fine. Let's just take it from the top, actually, Ryan, and yeah, just go. Yeah, they won't feature in the part final edit.
Okay. So these services are. I need. Sorry, I always start with so. I need to stop that.
It's fine.
Okay. These are quite complex services, and I think if you're going to try to broadly define what EMRS does, you can fit it into three different categories. So there's the retrieval of critically unwell patients, often from remote and rural healthcare facilities, and bringing them to the larger centres based in the major cities of Scotland. There's pre-hospital critical care, but also there's an important plank of clinical advice to remote and rural clinicians for patients that might be critical unwell. And generally, in terms of the evolution of the service over the 10 years that we looked at, I think that there are two stories. So the first of which is the relative stability of that interfacility critical care transfer services. And we might expect that given the relatively stable demographics that we see in the Scottish remote islands and the rural areas. But the other big story from this 10 years of national coverage is a really dramatic increase in pre-hospital critical care. So there's almost a 20-fold increase over the 10 years that we looked at. And that partly reflects the capacity to deliver that care, so the addition of extra teams, but also actually partly reflects a really huge amount of work that's been done to integrate EMRS within the Scottish Ambulance Service to ensure that tasking is appropriate. And one of the ways that we've done that is with clinician-led tasking as well, which is particularly important in areas as large as Scotland, where a single tasking might take out the team for a number of hours. It's not the same as pre-hospital critical care in major cities, where the impact of a tasking it might be a little bit less.
So just looking at the socio-economic impact of EMRS, could you maybe speak to, so the study you did was fantastic in many areas, but it really looked at the commonly dispatched socioeconomic areas or social deprivation, and it really sort of highlighted that critical care focuses or really is intrinsically linked to socioeconomic deprivation or social deprivation. Could you maybe speak to what implications this has on healthcare quality?
Yeah, this is something that's a real particular interest of mine, and I think I've grown up in medicine working in inner city emergency departments, and you really see at the front door of the NHS just how important socioeconomic deprivation is in bringing patients to emergency departments, but also really defining the outcomes after people come to us as well. It was something that potentially I maybe even worried about whenever I started working with the service, was that I worried that perhaps we weren't going to be in the place where people need us most, which is part of the reasons why we did this study in the first place, and part of the reasons why we looked at socioeconomic demographics as part of this study. We know people who are affected by social deprivation, that they're more likely to be critically unwell, they're more likely to experience major trauma, and these are really two of the key planks of pathologies that we hope to respond to. And what we found in this study was that if we look at EMRS as an example, we're responding to the most deprived areas 5 times more than the most affluent, which I think really gives an idea that pre-hospital critical care has the ability to mitigate some of the health inequalities that we know exist, particularly if we place them in the right place. So if we put pre-hospital critical care in an area like Glasgow that has a lot of social deprivation, we know that there's really the ability to make a difference to patients and to make a difference to health inequalities.
So just pivoting and looking at physiological indicators for a second, Ryan, could you maybe speak to the sort of the critical physiological indicators associated with pre-hospital mortality that this study addresses? So how do these inform EMRS's approach to patient care?
The physiological indicators that we've looked at is probably actually interesting, one of the hardest bits of trying to write a study like this. And I think it maybe actually indicates one of the real challenges in trying to do this kind of longitudinal research in pre-hospital care at the moment. We've got relatively little information to go on whenever we're trying to do these retrospective cohort studies. And we really struggle actually to link patients from the pre-hospital environment and into the hospital stays that they have. So this study particularly just looked at the indicators for pre-hospital death. And the second reason why we did this was really to try to update a paper that was published in 2006 that looked at the first year of EMRS, and they published the kind of illness severity that they were facing. So there were those two reasons that we did it. To be honest, with the physiological indicators that we've looked at, they don't come as a big surprise for anyone that works in pre-hospital care. If you've got a low GCS, if you've got an abnormal respiratory rate, or if you're in shock, if you've got a low blood pressure, these things are things that really make you much more likely to die in the pre-hospital phase of care. We have demonstrated that exists for our cohort, but again, I don't think that that's not something that's going to necessarily surprise any of the listeners that work in this area.
No, indeed, absolutely. And I think it also belies good community care because there is an extended, certainly in Scotland, and through the tyranny, as you said, tyranny of distance and tyranny of geography, the first few minutes in, certainly in significant multi-system trauma, it really does rely on good community care for opening airways and hemorrhage control before any formal critical care services arrive to the scene. Could you maybe speak to something which is absolutely fundamental, actually, and something we can't under stress or underemphasize, which is geospatial modeling, and indeed how geospatial modeling contributes to understanding, improving response models and operations, especially reducing transfer times?
Absolutely. And I think in pre-hospital critical care, we know that times of the essence. We know that we really need to try to get patients to the site of definitive care as quickly as possible. And the modelling in Scotland isn't straightforward. So even just to give you a couple of examples, so if we look at the Isle of Bute, Rothesay is 30 miles from its nearest MTC, but it's on an island and it takes over 2 hours to get to that MTC. We could look at Isla, 75 miles from its nearest MTC, but probably 5 to 6 hours by road. So it's really important that whenever we're having a look at these numbers, whenever we're trying to understand where our patients are, that we don't just draw straight lines on a map, that we really understand the geography that we're facing as well. And as you say, the tyranny of geography that we face in Scotland. So the geospatial modelling has been really useful because it allows us to understand the travel time rather than simply the distance that our patients might need to travel. And sorry, just give us well, maybe just cut
Yeah, that's
there.
fine.
And
Yeah,
then,
yeah, 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 yeah,
as you can probably see, I've got some notes here just to try and
yeah.
make
Sure,
sure I've got
right. No, it's
your
fine. It's fine.
So, okay, so I'll just give you a wee bit of overlap there as I go into the next bit, then, just in case that helps. So I think that really demonstrates that travel time is important, not simply distance, which is one of the reasons why it's very, very useful for us to try to look at that. Unfortunately, the published paper misses some of the things that really actually do demonstrate the availability or the operational reality to working in Scotland, and that is the Scottish weather, which has a huge impact in terms of dispatching our medical assets, but also can really affect us even enrolled and with ferry transfers for our patients as well. So I think it's important that although geospatial modeling does give us some of the answers, and it gives us some of the answers about how we maybe best deploy services, and as services grow and develop, how do we best respond to the patient need to get to where the patients are. But it's very, very difficult to account for some of those other factors. And these are factors that are throughout pre-hospital care. Weather affects us all to a greater or lesser degree, but particularly at the moment, whenever services are so stretched, the actual availability of assets and the availability of clinicians is another really key point that we maybe actually lose whenever we just look at the geospatial modeling.
So one of the aspects of a helicopter emergency medical service is that the expansion and the reach, and indeed the radius of care, can be ubiquitous. So one of the really interesting things is that, especially if you've got good governance behind the system, there's an increased leveling of inequality, and reduction of inequality of care as you move forward within a HEMS service. Could you maybe speak to how that's been addressed and indeed applied within Scotland, especially sort of rural and socioeconomically deprived areas? Because expanding EMRS, or expanding any HEMS service into rural areas, starts to give ubiquitous access of care, which is fascinating, because what it starts to do, I guess, it shifts the needle in really reducing morbidity and mortality. Could you maybe speak to that?
Certainly, and I think it's important to be clear at this stage, we know that pre-hospital critical care saves lives. And probably where we are now is trying to make sure that we do deliver equal access to that. We can go back to 1971. Tudor Hart published the inverse care law that says that our services are more likely to be in the places where they're needed least. We distribute services inversely proportional to need. And I think whenever I look forward as services grow and develop, and as HEMS services and pre-hospital critical care services throughout the UK and around the world develop, we really need to be targeting these areas which are relatively underserved. Because it makes sense to me that if we're going to go to the enormous expense of producing these services, particularly whenever we try to factor in the expense of our medical assets, we need to make sure that those are going to the patients who are otherwise underserved. And as you say, that might be by geographic inequality, and that we allow those patients to receive the best quality care as soon as possible, but also from the socioeconomic inequality as well. And that might often be located in the inner cities, but we know that from our experience in Scotland, that actually socioeconomic inequality exists throughout the country, and it's often actually more difficult to capture in those rural areas. Fundamentally, trying to make sure that we produce some access to early critical care services for the entire population is really the direction of travel. And it's really something I think is very, very important as we evolve these services that we focus on.
Tasking is a key element of any critical care service, really, ground or air-based service. Could you maybe speak to the expansion of the EMRS system within critical care tasking, and indeed its impact on patient outcome? How has tasking evolved over the past few years, and indeed what of the focus, what's the sort of focus been on tasking?
For us, I think tasking is incredibly important. Potentially less so for those services that are working within very constrained geographies where you can maybe more easily get back to base, or more easily be redeployed for where your next patient might need you. Whenever you're trying to work in an area with the geographic extent of Scotland, a single tasking really has huge potential because, as I say, we know that pre-hospital critical care saves lives. But we also know that if we take that team, if we take that incredibly scarce and expensive asset out of the game for a patient that doesn't really need us, that creates big problems. I think the Scottish approach has really evolved over the course of the last 15 years as we developed the pre-hospital critical care, both with physician staffed and non-physician staffed pre-hospital critical care, to try to make sure that we at least have a degree of clinician uh, presence at the point of tasking. And certainly, whenever you have a look around the literature, you'll find that there are various experiences of clinician versus non-clinician tasking. But I think actually the Scottish experience is one that shows that there's probably more nuance to that. We can't simply divide tasking into people who are clinicians and people who are non-clinicians. Our experience has really been that if we put people who are really familiar with pre-hospital critical care, with clinicians that work in these services, we definitely find that we task to more jobs, that we deliver more critical care interventions potentially, and we have fewer stand downs. And for a service like ours, where you're trying to cover an enormous geographic area with relatively few assets, that is really critical.
Yeah, absolutely, absolutely. So, could you speak to the mortality factors, some of the key factors associated really with pre-hospital death identified within the study, and indeed how EMRS address these factors within its protocols and SOPs?
Yes, this is a really tricky place, I think, for pre-hospital critical care research at the moment. So most of our data sets, particularly in the UK, if we think about the TARN data set that we've done a lot of our work with, the retrospective studies looking at trauma mortality, these are really data sets that only start including patients after you've reached it, after you've made it to hospital. So there's a huge component there of patients who are potentially alive at the arrival of the first clinician on scene, who then go on to die in the pre-hospital environment, that simply are not considered in most of the literature that we're reading at the moment. So that was one of the reasons why we thought it was very important to try to include those patients. Unfortunately, I think whenever you try to really explore the factors that are associated with pre-hospital death, particularly in a relatively small service in a one aspect of the country, is you simply don't either have the power in terms of numbers, and you don't have the depth of data that you would have in a really in a national cohort study. The things that we have found that contribute to pre-hospital death are, I think, the things that we expect as clinicians. They are abnormal physiology, low GCS, abnormal respiratory rate, low blood pressure. Perhaps there's some value in at least confirming that those things are markers of a poor outcome in the pre-hospital environment. Perhaps that allows us to potentially task these services to those patients where we can determine that quickly. But apart from that, I think that there's still a lot of work to be done in terms of trying to really shift the dial on those patients that die in the pre-hospital environment, particularly those that die in the presence of pre-hospital critical care.
So just coming to land slightly, just a couple more questions, Ryan. One would be around retrieval, and there's been a lot of empirical research on reducing the amount of secondary transfers, or indeed the time for secondary transfers from primary point of contact, just to reduce and again the whole major trauma network has been evolved to reduce secondary or tertiary transfers to point of definitive care. But could you speak to how, just fundamentally from history and the history of the EMRS, how some of the aeromedical retrieval by the EMRS has really reduced these transfer times and indeed improved efficiency and indeed patient outcome by reducing time to definitive treatment?
Yes, it's so important for our service to be able to try to reduce those transfer times. And unfortunately, actually, in the paper, the initial figure that we had that compares the times by road and times by air in Scotland is still misprinted, despite me asking for it to be changed. But really, whenever we do look at that, what we find is that we really shift the dial with aeromedical assets and the provision of aeromedical critical care to bringing the transfer times down. And the numbers in a geography like Scotland are huge. So we're not reducing by minutes, we're reducing by hours, these patients getting to potentially their definitive treatment, be that neurosurgical intervention, or for some places, even the presence of a CT scanner. it's really interesting talking about secondary transfers in Scotland. And I think this is one of the places where it's so important that we consider the local geography. So a patient that becomes critically unwell in the Western Isles, they have no option but to go to their initial point of contact in terms of the healthcare service. So I suppose for us, a secondary transfer really means trying to make sure that we bring the patients from at least from their first point of medical contact, be that a rural and isolated GP surgery, or be that one of the rural general hospitals, and making sure that they go to a centre that is at least able to provide them with really comprehensive care as well. And certainly the presence of EMRS allows that to happen safely in terms of the ability to safely transfer patients that are potentially ventilated or with ongoing vasopressors, but also to really make sure that we operate with clinicians who are experienced in that in-hospital environment as well. So they know the different levels of critical care that might be available in the different hospitals and allow that primary triage to be to the right place.
And absolutely makes sense. And like you said, there's a lot of what I actually interfacing and interacting with a lot of GPs within Scotland is actually it's extremely difficult for them because they do have to be generalists because they're the first point of call for trauma and indeed acute medical for a lot of these places because you're right, there is no other option for the population in these rural and remote areas. They have to be really proficient and competent in a lot of in a lot of kind of acute circumstances and pathology, which is extremely difficult because normally you'd expect, especially in a heavily urbanized system, there's escalation to critical care quite quickly. But in these some of these cottage and indeed remote areas, it's really tricky for these clinicians.
Absolutely. And I think it's been probably one of the great privileges of my professional life is to have spent a month on Hoy, which is one of the small Orkney Islands, population around 350, and spending that month with the local GP on call 24 hours a day, up to 16 weeks at a time, dealing with everything from chronic disease to critical illness and everything in between. Literally traveling around that small island with a portable ECG machine and a briefcase full of thrombolysis in case someone has a STEMI. And whenever you see both sides of it, it really makes you appreciate, first of all, just what a valuable job these remote and rural clinicians are doing, often solo, often in the middle of the night. But also, I suppose it allows you to recognize the really important work of a service like EMRS to be able to be an interface for those clinicians, hopefully being able to take those critically unwell patients off their hands and move them to somewhere that is able to deliver the safe care that they need, but also in the interim to be able to give them good, safe clinical advice to look after that patient in the short term. And I think probably the other thing that perhaps out of this context is harder to understand is realizing that these clinicians are really embedded in those communities as well. So the ability for them to continue to deliver that continuity of care to a patient whenever they return from their critical illness or with their family, we hope that we're able to help that by being able to provide a second port of call or I suppose the clinical advice that we're able to give to those clinicians. It allows that to be delivered in a way that's really far more sustainable.
Something you just said is really interesting, Brian, actually, around this clinical advice. And because, like you said, it might not be an option that they actually wait for 2, 3 hours until they have formal critical care by bedside. But the lifeline is, like you said, just having a second opinion, a second pair of eyes or ears, just to advise them through some sequential steps to optimize care until there is an escalation of care, and even that is reassuring, and it is also there's a governance aspect to that which can be at play, but there is it's an extra level of care and indeed reach back, which is fantastic to see.
Absolutely. And I think it's something that for those of us that are lucky enough to work in big teams, we take that for granted. We take for granted the easy ability to ask for an opinion of a colleague or a formal second opinion. But really, for a lot of our clinicians, they are working completely independently and being able to provide even that hopefully friendly listening ear at the end of the line. Hopefully, it allows them to be able to deliver a better job and to be able to do that, as I say, more sustainably in the long term.
Just gonna kill this. It's just someone calling me. Okay. Okay, this final question. This won't appear on the final edit. Okay, perfect. I'll just go in with this. So finally, Ryan, if we could just speak around future directions for the EMRS, how do you see its role evolving in the next decade for future improvement of indeed critical care and emergency medical care within Scotland?
I think the future is always really difficult to predict, but I'll give. Sorry, I'll try that again. Um, I think the future is always really difficult to predict. At the moment, we've just been through reprocurement, particularly for the aeromedical aspect of our work, which hopefully gives us some more resilience to the Scottish weather and allows us to be able to deliver that care more reliably than potentially we have been able to at times in the past. I think that the service at the moment is really at a point where it's demonstrated its utility to the Scottish people, but it's always important, particularly in times whenever funding is tight, that we continue to demonstrate that we're operating as effectively as possible. I think there's huge challenges coming down the way of pre-hospital critical care, particularly as some of the very high resource intensive interventions, for example, ECMO, for example, thrombectomy, start to become more available. And how we deliver that in a place like Scotland, where, as I say, we're covering 77,000 kilometers, we're covering 93 uninhabited islands, or inhabited islands, sorry, many more uninhabited ones. And trying to make sure that that is able to be delivered equitably across a population is a real challenge. And it's something I think that having the service there, really being able to advocate for trying to reduce those geographic inequalities that we see is really, really important. But it will certainly be a challenge for the service as we try to adapt to what might be coming on more online in terms of those resource intensive interventions. I think the other big aspect is the general development of pre-hospital critical care, which certainly in Scotland has developed beyond recognition in the last 20 years. As I say, a 20-fold increase in the number of pre-hospital critical care jobs that EMRS are doing. So as we move away from those emergency medicine based flying squads of doctors heading out in a car based from an emergency department, as we support the development of pre-hospital critical care paramedics and other clinicians to deliver pre-hospital critical care, and trying, I think, importantly, to ensure that we deliver that same equity, either for geographic or for social deprivation that we see, and fundamentally trying to make sure that we're there for those who need it most.
Listen, Ryan, that's fantastic. And just want to say thank you for the last 40 minutes, but also thank you for the study. It's hugely insightful. And I think there is some real lessons learned from the study that other critical care systems can extrapolate and take into their systems. So what we'll do within the show notes, we'll put links to the study because I think it's a fantastic read just to see the evolution of critical care within Scotland and some of the lessons learned and like I said, take on messages that other schemes can learn from. But thank you for the last 40 minutes. It's been hugely insightful and informative.
Thanks very much for having me on. Pleasure.